We're live? Great. Hi, everybody. I'm Dr. Cady from Cady Wellness Institute. There are a number of ways to give a program like this. One is with the PowerPoint illustrations behind and a projector, but I thought with this intimate setting, it would be more appropriate for me to just talk to you all. So, let me tell you a little bit about how I got here and why I'm doing what I'm doing. My first career was as a performing pianist. I got 2 degrees in piano performance, and I actually made a living doing it for 3 years. But medicine was always a childhood passion, and so I went back, got into medical school, and subsequently trained in psychiatry at Mayo Clinic in Rochester, Minnesota. Now, that was one of those good news, bad news kind of things. The good news is you probably heard of the place. It's famous and deservedly so because it takes Western allopathic medicine and pushes it to the limit. If you have a brain tumor, you want to go to Mayo. If you have severe rheumatologic disease, you want to go to Mayo. If you're psychotic and depressed, you want to go to Mayo. But if you just want to be well, that's probably not your place because Mayo is kind of, by the way it was designed, a classic Western medical place. Don't get me wrong, I loved Mayo. I wouldn't trade my time there for the world. But when I came to Evansville, I began to realize that there were other things besides what I had been taught. So I came to Evansville as a conventionally trained psychiatrist. What do psychiatrists do? Well, they see people who are depressed or ADHD, or in some cases have bipolar disorder or psychosis, and we fix them. So, in the first 2 to 3 years of my practice here, I slung Prozac with the best of them. I mean, there were people that would come into my practice that were not on the optimum combination of drugs, and that's the reason they were still depressed. So I just fixed it. And after 3 years, I ran out of patients to fix because I'd fixed everybody. So then, at least with what I could do. So then people came in to see me, and antidepressants weren't working for them. They were referred in with the presenting history of my doctor says I failed every antidepressant and that I need to see a psychiatrist. So there they were. For a while, I just accepted what the local doctor said. Their thyroid is fine, their hormones are normal, there's nothing wrong with you, etc. By the way, I have a total experiential learning activity for you in a second, and we'll talk about where your hormones are in your body and where they're going. But for right now, let me just continue. I got interested in hormone replacement therapy. I worked with a absolutely amazing naturopath physician who practiced with me, Dr. Whitney Gabhart. She saw the patients. I wrote the scripts. All right. So anyway, I got started with hormones with Whitney, and then I did some independent study and ultimately ended up teaching a course in hormone replacement therapy for doctors and nurse practitioners and PAs, and brought back everything that I learned to my practice. So what I discovered, and the reason we're here, and the reason we have a wellness institute and not a psychiatric institute or a medication institute, is that I found that people needed more than prescription medication. Sometimes they need their hormones balanced. Unfortunately, frequently people will go to their doctor and they'll say, I'm tired, I'm depressed, I can't lose weight, I feel run down. I have had women tell me from their lips, I'm mean, bitchy, and irritable. I'm not describing them that way. That's what they tell me. Okay, just to be clear about that. And I began setting out to try to figure out why these women were that way. And it wasn't because they hadn't been given enough antidepressant because their doctor had done that. So let me tell you about one of the big offenders in hormones that is missed and misdiagnosed, and that is thyroid. How many of you, I'm not going to ask you personally, but how many of you know of somebody that has gone to the doctor and said, I feel tired, I feel run down, I'm gaining weight, I can't stop it, I don't know what's wrong with me, and the doctor checks your labs and says, all of your labs are fine? How many of you know somebody like that? Okay? You? No, I'm talking about people you know. You know anybody? Okay, one person here. Oh, you kept me from being unanimous. But the interesting thing about that is it depends on which hormones you look at and what reference range you use. And just go with me for a second, and then we'll get to what else we're doing. And we're going to have half of this is going to be Q&A. So I will be here and I will answer your questions until you're done. And if we run out of time, we'll go over there while the next person comes and presents. Okay, so I'd like everybody to stand up. Put everything down behind you. I will tell you that I'm now a neurolinguistic programming advanced practitioner. So in neurolinguistic programming, they talk about the four methods of communication: auditory, visual, digital, and kinesthetic. So we're going to do it all. So here's how and I want you to mirror me. This is how physicians check your thyroid. Point to your head. They check your pituitary hormone that stimulates the thyroid gland. That's called TSH. Okay? That's all they check. All right. But TSH doesn't do you any good in terms of the end effect. So TSH goes down to the thyroid. Y'all catch on quick. And the thyroid secretes thyroid hormone. That's pretty straightforward, right? T4. Okay, but that's not the end of the story. That still doesn't do you any good. T4 goes down to the liver. Touch your liver. It's on the right side, upper right, upper right. Good. You all got it. You know where your liver is. And in the liver, T4 is converted into T3, which is the active form of thyroid hormone. And if your doctor has checked all of that, good. You've got a pretty good doctor. But there's one more. Point to your kidneys. Use your thumbs and point to your kidneys, the top of your kidneys. That's where your adrenal glands are. And your adrenal glands secrete cortisol, a stress hormone. And when they secrete cortisol, they take, okay, so you got your thumbs here. Now, they take T4 and change it to reverse T3, which goes all over your body and it blocks your thyroid hormone receptors. Yeah, great. So if that is not checked, you don't know what's going on, and they don't know what's going on. Okay, do you want to do that? Let's have a quick review. TSH from the pituitary, thyroid hormone from the thyroid gland, conversion to free T3 in the liver, the evil twin stuff back here from the adrenals that are secreting cortisol. Okay, y'all got that? Okay, have a seat. Now, let me tell you the reason. By the way, how many of you, well, can I ask you all, how many of you have ever had your thyroid checked and did the doctor say you're fine? You had most of your removed. Okay. So the reason that happened is physicians are trained to check TSH. That's it. And they are trained to treat only with T4. That's it. Synthroid, what comes from the thyroid gland. There is no consideration of reverse T3, the T3 going to the receptors, and then there's the question of what the range is. So I was talking with a woman at my table earlier today, and she said, yeah, I'm not quite sure about all of Just telling you what she said. I'm not sure about all this holistic stuff because I've tried a bunch and it hasn't worked. And there are some very good providers here, by the way. But the problem with a reference range of drugs, like and hormones, this is the bottom level, this is the top level. Okay, you understand this concept of reference range? Okay, the reference range is defined as what's in the middle from I'm going to tell you the technical, then I'll tell you what it really means. From -2 standard deviations to +2 standard deviations of the value. So what that means is if you take 100 people and line them up against the wall with the absolute bottom hormone level as person number 1 and the absolute top hormone level as person number 100, and if you're standing there and you're person number 3, you're normal. What about if you're person number 97? You're normal. That's all described as normal, and it even gets better because that distribution is age dependent. So as you age, the levels that are considered normal for your group go down. So you might be solidly in the middle for your age, but feel like crap because the hormone isn't adequate to support you. So I told you about thyroid. Same thing with estrogen, ovaries. Same thing with estrogen and progesterone. Same thing with testosterone. You might be within the reference range, but you won't be feeling it. So basically, I got really interested in this. Worked with Dr. Gabhart, one of my heroes, and we got really good at balancing hormones. And what we do is we bring them up into the optimum range, not just fair to middling, but optimal. Now, let me tell you one of my favorite stories. Age management for cars and conventional medical practice for cars. You with me? Y'all have cars? You want them to last? You want yours to last? You want yours to last? Everybody wants their cars to last. Okay. So here is age management medicine for cars. It is known that oil gets dirty with age. It is known that transmission fluid breaks down. It is known that tires go bald and you lose your paint and your brakes fade away and they're all deteriorating. Okay? We should do something about that. That's what age management medicine says. Let's change the fluid. Let's change the tires, etc. Okay. You know what Western allopathic medicine says? If you think about it, deteriorating oil and transmission fluid and brakes and tires are all part of the aging process. It is unnatural to intervene. That's Western medical practice. So if you're a menopausal woman and you have menopausal level of hormones, you are told your labs are normal. Because by definition, for your age, they're normal. Because at your age, your hormones are dropping down. So we got really interested in that and began doing a lot of hormone replacement therapy. A lot with my colleague Whitney Gabhart, and then my nurse practitioner Margaret Johnson and I have been doing it extensively since then. I teach for National Procedures Institute in Austin, Texas, as part of the Texas Academy of Family Physicians. I teach a 16-hour course in how to balance hormones. It's 16 hours of contact time in 2 days. So the people that come actually get 16 hours of for real continuing medical education. So it's the real deal. That's what we do. Okay, so let me change for a moment from hormones to what really brought me here, which is psychiatry and mental health. So when I came here, I told you my history. I was treating depressed patients, and I said, "Is your thyroid okay?" And the doctor said my thyroid is fine. Okay, so I got interested in hormones. That's true, but there are things that can be done in mental health that do not involve jacking your Prozac level up. There is something called an MTHFR polymorphism. You don't have to remember that, but just remember that if you don't have this enzyme, you can't make enough L-methylfolate. Hear me out. I'll tell you what to really remember. If you can't make enough L-methylfolate, you can't make enough of your happy neurochemicals, serotonin, dopamine, norepinephrine. The answer is not more Prozac for a depressed person or more Ritalin for a hyperactive munchkin. It's let's fix the underlying problem. So that's the functional integrative part of what we do is we look at the fundamentals. So one of the things, for example, that happens when I see patients and they come in and they don't know what's wrong with them and I don't know what's wrong with them and they're coming in for me to scratch my head and figure it out. That's a 2-hour intake, which is roughly 200% of the normal intake because insurance will not pay for more than a 1 hour intake. So accordingly, I don't take insurance because I'm going to see him 2 hours or until I get the history. One of the things that's interesting in the mental health field is the family medical history as well as the family psychiatric history. Yes, I want to know about their psychiatric history, but I want to know about the family medical history because here's the take home thing. If you have a gene defect on the major gene for what's called MTHFR, if you're a woman with a MTHFR deficiency, you have 9 times the risk of miscarriage. So my question to the person sitting in front of me, let's say it's a woman that's depressed. Any female family members in your family, mom's side or dad's side, have problems getting pregnant, staying pregnant, or delivering a baby with birth defects? So that's for the depressed ladies. But what about the mother that brings her little hyperactive jumping Johnny in? I'm still going to ask because what happens is for someone with ADD, if I put them on a medication which boosts their dopamine, which helps with concentration, and they can't make enough of it because they have this MTHFR deficiency, then the natural history is little Johnny will be doing absolutely great for a month or two. And then the medication stops working. So little Johnny goes back to the doctor or the healthcare practitioner, and they say, oh, well, little Johnny needs more Ritalin. So then go up on the Ritalin. Again, it works great for another 2 months, but then it stops working. So then the practitioner says, oh, little Johnny needs more Ritalin. And then little Johnny goes to class and stabs the teacher in the leg with his pencil. That's the hit. Now, the reason that this is happening is there's not enough methylfolate because of this gene defect so that you can make enough of your happy neurochemicals. So, what is the what?
What does the Ritalin do to that?
What does the Ritalin do? The Ritalin blocks the reuptake of dopamine back into the pitching neuron. There's a pitching neuron and a catching neuron. The pitching neuron pitches out dopamine. The catching neuron says, gimme. And the dopamine binds there and does dopamine things to the brain, which include feeling good, being happy, and also being able to focus and pay attention and stop wiggling. Okay, but you got to make it. So the Ritalin blocks the reuptake, so it's out there floating around. Some of it comes back, not all of it, because there are enzymes out there that gobble it up. One is called catechol O-methyltransferase, another is monoamine oxidase, which reminds me of something, and it gobbles the neurotransmitters up. So eventually, your amount of neurotransmitter in the brain goes down, 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 down. Then you don't have enough because you can't make it fast enough. So by simply one supplement, L-methylfolate, you can take care of that. With L-methylfolate, you can keep a woman of childbearing years safe from having a miscarriage or a baby with spina bifida, just with L-methylfolate. The question is, how do you test to see if somebody has that? You test for, it's called MTHFR genotyping, and it is a standard LabCorp test. Medicare, conventional insurance plans, Medicaid, HIP, they all pay for it. MTHFR. Just think about the somewhat obscene thing that you could wrap your mind around for that, and then you can remember it.
It used to come on gene testing too. It used to be on 23andMe, but not anymore. On the backside, you can see.
Right.
Okay, but I didn't know. Now I did it that way.
That was one of the genes that you were testing. So let me repeat for the film crew over there and for the rest of you the question. Well, I've had gene testing. I had 23andMe, and that's one of the things that showed up on the back. Yes, 23andMe is a really good test for getting a complete idea of your genome, but sometimes it's a little impractical. So what we use in our practice is a lab called Genomind, which involves only getting a cheek swab on your inner cheeks, and my staff will scrape off some cells, and it gets sent to the lab, and then it gets amplified. That little bit of tissue gets amplified the way they do it on NCIS and so forth, with the gene testing, the DNA testing, so they can make enough of it so we can see. And with that test, it's not only the major and minor gene for MTHFR, but it's things like, do your serotonin reuptake pumps in the brain work? And if they're already blocked, if they're kind of lousy functioning, then SSRIs won't make you better. I mean, I can do that gene test and say, okay, forget Prozac, forget Zoloft, forget Paxil, forget Luvox, forget Celexa, forget Effexor, forget Pristiq. There are other things that you should use. Just with that, it makes it so ridiculously easy. I'll tell you what I tell some of my patients. Let me check my time because I want to make sure that we have time for Q&A. I told my patient that this is like breaking out a map to New York City. If you want to go to New York City and you don't have GPS, which is hardly likely these days, but if you don't, you break out the map to see how to get to New York City. You see what roads you want to take. You see what turns you want to make. Does that make sense to everybody? Okay. Well, the Genomind test report is the map to how you want to get to where you want to go, which is, in my definition, total happy campers, lots of vitality, no mood problems, no fatigue, no depression. If I'm treating psychosis, no psychosis. If I'm treating bipolar, no manic crazy stuff. That's where I want to go. And that test helps me get there. So that's largely what we've been doing. Oh, I do need to tell you something. On our table, there's a trifold, and on the back of our trifold is a picture of my nurse practitioner, Margaret Johnson, and me. Margaret couldn't be here today. She's been in Italy, poor thing, and she's coming back, so she's not even in the country. So Margaret does something called intramuscular ketamine. So some of you may have heard of the ketamine clinics. There's one in town. I won't use any names. But basically, at some of these ketamine clinics, you go in, you lie in a dark room, they put an IV in you, they run ketamine into you for about an hour, and that's it. That's the treatment. Sometimes it works, sometimes it doesn't. Sometimes people have bad trips. One of my patients had the sense that he was dying during his trip. So Margaret does it differently. Number one, we use intramuscular, which has a little bit smoother action, just in the deltoid, just where you'd get your flu shot or whatever. And she's there in the office with the patient that's doing the ketamine journey, as she describes it. She is a trained therapist, and she flat out does therapy while they're under the influence of ketamine. Now, she doesn't, rape their brain or anything, but if something comes up and the patient wants to talk about it, they talk about it. So this is an unheard of level of sophistication using ketamine in this community. I don't do it. Margaret does it, and she does it wonderfully. So, what's ketamine good for? Depression and PTSD. Those are two things.
Does it help people with traumatic brain injuries?
The question is, does it help people with traumatic brain injuries? Not so much. But there are things that will help people with traumatic brain injuries. If I may have your permission to riff on this a little bit, I'll answer that, and then we'll wrap it up here in a second, and then we'll take lots of questions. But for traumatic brain injuries, there are several things. Number one, you want to have enough essential fatty acids. You want to have enough of your neurotransmitters, dopamine, norepinephrine, serotonin. For that, you may need L-methylfolate if you have an MTHFR deficiency. You need anti-inflammatories. That would be like curcumin or turmeric. You need hormones. So I'll give you a reference. The reference is The End of Alzheimer's by Dale Bredesen. And Dale Bredesen, who's an MD, a neurologist,
Is that a book?
it's a book.
Okay.
It's a book. The End of Alzheimer's. And we're talking about traumatic brain injuries and what to do. In this book by Dale Bredesen, The End of Alzheimer's, he makes a couple of points. Number one, there is never going to be an Alzheimer's drug that will work, ever. There's not going to be a magic bullet for Alzheimer's. Not like you have strep throat, great, let me put you on penicillin, kill the bacteria, you live happily ever. It's not going to work like that because there is so much damage in Alzheimer's, and there's damage with traumatic brain injuries. So Bredesen says, yeah, that's not going to work. There's not going to be a single drug, but the perfect drug for Alzheimer's would have all of these characteristics. And that includes everything I've been talking about today. Making sure the thyroid is right, making sure the estrogen is right, the testosterone, the coenzyme Q10, the B12, the B vitamins, the antioxidants, the vitamin C, the vitamin D, which most people here are deficient in. All of those things are necessary. And with Bredesen, he talks about the keto diet. I have tried his protocol with two patients. They both faded off into the sunset demented. The reason they did is they would not do the diet.
They were not what?
Do the diet. You'd think you'd be motivated, but by that time it's like, oh, what me worry, and so I'll eat the ice cream and the peanut butter and so, yeah. So there's one patient that my nurse practitioner is treating with that protocol, and he's actually gotten better. Bredesen has published in the peer-reviewed medical literature about how he took patients, including some doctors, from demented to back to full function and returning to work. So peer-reviewed papers means the author writes the paper, says this is the theory and the notion that I am advancing, and it's circulated among the peers, and then they say, yeah, it's a good paper. No, it's a lousy paper. Here are the study problems. Here are the strengths. And if the peer review says it's a good paper, then it gets published, which means that you can't publish crap in the peer-reviewed medical literature because it ain't going to be peer-reviewed positively. It will not be published. One other little tip for those of you that are taking notes. The world's peer-reviewed medical literature is yours for the taking. You go to www.pubmed.gov. pubmed.gov. Okay?
Is there a better possibility that you can get cured?
If you catch, yes, helped or cured.
Yeah.
Okay, so I'm going to give you the holistic integrative medicine perspective, which is basically standing on top of Bredesen's work. The sooner you do something about it, the better. There are some drugs, yes, I still use drugs, that will diminish the damage, but that's not the only thing that has to happen. The diet has to change. You have to get more fats in. You have to do things that nourish the brain. There's several natural substances. They're called nootropics. 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 Huperzine, vinpocidine. Chelation can be very helpful, particularly if your arteries are clogged with plaque. Yes, can definitely. And also chelation is helpful for getting toxic metals.
That'd be cool. The only place is Fishers. It'd be cool if you guys offered chelation because there's nowhere around. You have to go to Fishers in Indiana.
All right. The feedback from the audience is you ought to offer chelation because you got to go to Fishers, Indiana to get it. I will take that under advisement. Okay. All right. Or Louisville. So do you all understand that I've been talking about functional, natural things to do, not just jacking people up with pills and medications? Okay. Now let me tell you about hormones and aesthetics. How many of you have heard of people that have had Botox? I'm not asking you personally, but you've heard of people that have had Botox. Botox for anything. Yes? Okay. How about fillers? Things. Okay. All right. That's unnatural. That's shooting it in from outside the body. And Botox is a toxin. It will kill you if you get too much of it.
Don't they give that for migraines?
They give it for migraines. They give it for facial wrinkle lines and so forth. So Botox and filler. Also, it's very expensive. It's like $800 for a full face for Botox. It's about $8,000 for a full face with filler. And this is important. This is important. With fillers, well, first of all, with Botox, it's shot in with a needle. The needle can hit a nerve in the face, and then you lose feeling. If you kill it, that's it. It ain't ever coming back. All right. How about the filler? The filler, if it gets inside a blood vessel, will occlude it, and you will basically have a stroke downstream. So you get tissue necrosis. And this is reported in the peer-reviewed literature, PubMed. If it's put in around the nose and here, you can go blind. So that's risk, benefit. Yes, your face will plump up. Do you want to take the risk? Me, I like to do it naturally. So that's what we've got. We have the so-called M-Face, which stimulates your facial muscles. It's like sit-ups for your facial muscles, plumps them up, and it shoots radio frequency into the subdermis so that you make more collagen and hyaluronic acid naturally. So it, yeah, no, it's not a lotion. You make more of it yourself. Now you can use collagen, hyaluronic acid, and facial cream, but this you make it yourself rather than having to have it shot in with filler. So that's our functional aesthetics program. So I think that's basically pretty well. Oh, sorry, one other thing I needed to touch on: the GLP-1 agonists. They're all over the news. Ozempic, Mounjaro, Saxenda. They're the weight loss shots. I have actually recorded a video on the upside and the downside of the GLP-1 agonists. It's on our YouTube channel, which you can write down, CWI, that's short for Cady Wellness Institute, YouTube.com. Don't go to youtube.com, you'll never find it. Use CWI, youtube.com. You'll land on our own little corner of YouTube, and it's all there. So in this presentation on GLP-1 agonists, I made the point that yes, you can lose weight with it. You don't want to lose weight too fast because then you become a Ozempic junkie. You really don't want to lose it too fast because then you get Ozempic face and Ozempic butt, which is why I got some of the functional aesthetic stuff that we've got. So if I have a patient on a GLP-1 agonist, or check this out, something that will help your body make more GLP-1 naturally, not a medication, a supplement. There is one exhibitor here that has such a product. So go around and look for it. If you're losing weight, you're going to lose fat because with the GLP-1s, you lose it all. It basically kills your appetite. Your gastric emptying slows down. Your satiety centers in the brain says, I'm full, I'm full, I'm full. And so it's easy. You look at a chocolate chip cookie and walk away from it. Just there's no craving for it. But the problem is when you do that, you have decreased consumption of everything. So you have decreased protein consumption, which you need for your muscles. You have decreased fat consumption, which you need for satiety and also to make your myelin in the brain. And you have decreased carbs. Now, decreased carbs, that's probably okay, but you gotta have the protein. So those devices help. We also have some collagen that we use at CWI and also our functional aesthetics gear. So that's basically it from the beginning to now. That's everything we do. Does what I said make sense to you? Okay. Now at this point, you got me. As long as you want to ask questions. So I'm gonna answer them here until you're done. And if somebody else comes over here, we'll go over in front of Azteca Mexican cuisine. What questions? Yes, ma'am.
You mentioned insurance, but I was struggling to hear you. So, do you take insurance to help pay for your services?
First question is, do I take insurance? No. For a follow-up question, why don't I take insurance? Because they wouldn't pay me to do what I do for patients.
Do you suggest and also can you still see your regular doctor if like doing hormone therapy with you?
Totally. The question is, could you see your regular doctor if you're doing hormone therapy with us? Sure. I'll even, if you sign a release of information, I'll even send a report to the regular doctor what we're doing.
How would I set up an appointment with you to discuss hormone therapy?
How to set up an appointment to discuss hormone therapy. Call my office, say, I want an appointment to discuss hormone therapy. Now, if you just want a little quickie howdy doody, how this would work, come on in, no charge. If it's like, and I have no idea about your medical history. If there are significant hormone issues that are going on and you want to come in and say, I need my hormones evaluated, that's an hour appointment. And if you were to tell me something like that, we'd try to get your labs done before you came in. So I'd have them right there and I could say, okay, this is the reason you're feeling the way you're feeling. Does that totally answer your question?
Yeah.
Excellent. Next question. Do I use specific labs?
For your LabCorp or Quest or
I will use labs from anywhere. Deaconess, St. Vincent's, LabCorp. I prefer LabCorp because we have a entry into their portal. So if you have a LabCorp test anywhere in the country and I order it and my name is on your order, I can access it. Or more particularly, my staff can access it. I say, find those labs for me. Yeah. Other questions? The question is, so if I got my labs done and then came in for an appointment, would that be the best way to do it so we could get going? Yes. Other questions? What kind of test do you ask for? Well, thank you for that question. I'll tell you the kind of test that I would ask for. Okay. And I really didn't set her up for this. Okay, y'all stand up. Everybody stand up. What are we checking? You got it here after this. What's this? TSH in the pituitary. I'd get that one. What's this one? T4. What's this one? T3. What's this one? Cortisol. So reverse T3. I would check all four of those. Your doctor is typically, or your healthcare practitioner is typically going to just check this. That's it.
If you ask them to do it, will they do it?
That is an outstanding. Okay, the question is, if you ask them to do it, will they do it?
Maybe.
Who knows? It all depends. Here's a great quote for you. Whatever docs are not up on, they're down on.
Yeah.
So, and if they order that lab for you, they are now responsible for you and what's going to happen. If they don't understand the reason for that lab, they probably won't order it.
And would it be called a complete thyroid panel?
It wouldn't necessarily be called a complete thyroid panel, because that little checkbox on the conventional lab, you get TSH, free T4, T3, free thyroxine index, thyroid, I think thyroid rehab. These are not the labs I need. I need TSH, T4, T3, reverse T3, and if there is a history of thyroid disease in the family, anti-thyroid antibodies and anti-thyroglobulin antibodies to see if your immune system is munching on your thyroid. And that's just the thyroid.
Cancer of the thyroid is not considered thyroid disease, though.
Oh, it's definitely thyroid disease, but it's not, and it depends on the type of thyroid cancer. Yeah, depends on the type. Yeah, but that's just the thyroid. Then now we're going to go down here. Estrogen, progesterone, testosterone in a woman, DHEA over here. Oh, sorry, DHEA from the adrenals, because that gives you energy, helps balance blood sugars. IGF-1, which is a downstream product of the pituitary. You make growth hormone, goes to the liver, you make IGF-1. Those are things. CBC, critical. That's a conventional lab test, but I have had many women come in, they're tired, they're depressed, they got no energy, their doctor has told them all their labs are fine, and lo and behold, they're anemic. And if I start peeling the layers back, they're iron deficient. So those are just some of them. Oh, that's such a good question. In a complete blood panel like that, do they test for ferritin? Ferritin. I test for ferritin if there's any indication that there's a problem with iron. Ferritin is like the total body supply of iron. So you can't just check serum iron, you got to check ferritin and percent iron saturation. Lots of different things that should be checked. Okay, so the question is, so would it be represented with a regular problem panel, like you've got a problem, we need to do that? Well, if it's read correctly, if the physician realizes that a hemoglobin and hematocrit hovering on the border of flat out abnormal might not be a good thing, then that would be helpful. If they don't, it's like, you're pretty normal. You're between the third person and the 97th person lined up against the wall that we talked about. 2 standard deviations, either side of the mean. This gentleman has a question. Yes. Oh, that's an excellent question. Gee, well, they're all biomarkers. The question is, if I come in and get a comprehensive blood panel, how many biomarkers on there? Well, everything that I order. So all the thyroid, you're a dude. So I'd get LH and FSH from your pituitary that go down and stimulate your testicles to make testosterone. I'd get a free and total testosterone level, not a total, a free and a total testosterone level. I'd say you're probably over 40. Would that be safe to say? I'd get
that's a long, small dot in my
I'd get a PSA on you. And if you told me that there were women folk in your family that had had difficulty getting pregnant or staying pregnant or having miscarriages or babies with fetal defects, I would order an MTHFR on you. If you said, Doc, I heard an ache all over my body, I would order inflammatory markers on you. CRP, IL-6, HSCRP, ANA. Those are some of the inflammatory markers that I would order. Okay, we're coming to an end of our time together. My goodness, it's ma'am. The question is, am I accepting patients now? And the answer is, heck yeah. And so is my nurse practitioner. No, it's not. 500 for an hour, roughly. 900 for 2 hours. Seriously. And for a quickie little med check, it's about 185 for a half hour. Now I'm quoting my prices. For a half hour, it's like 235. Market is somewhat less expensive than me.
Do you take payment plans at all?
We are getting, the answer is no, not yet, but we're about to. Do we take payment plans? Cherry and Care Credit we're looking at. The question is, who determines who you see versus who your nurse practitioner sees? The quick answer is my staff. But the more deep answer is, if you call the staff and say, I want to see Cady, you will see me. If you say, I can't afford Cady, I need something less expensive, they'll refer you to Margaret. Margaret is like, she didn't like me saying this, but she's my mini me. I have trained, she knows everything I know. I've trained her. She's been to my hormone replacement therapy courses. She's eminently qualified. So that's how you would determine.
How many sessions would you need?
How many
Sessions?
sessions? Well, for one thing, if you were coming in and you were just this big question mark of what's going on, probably 2 hours. If it's like, okay, doc, I know that it's my hormones, that's what I want to get worked on, that's an hour. And then after that, when you would come back and we would review the labs. Oh, and this is on my website, our unique process, the wellness introduction, the neurovitality interview, the body systems diagnostics, the labs, the therapeutic synthesis appointments, that's all there. So 1 hour at the beginning, probably 1 hour for follow-up, and then by that time I've probably got everything kind of massaged into place. And then after that, 30 minutes or 45. Some of my patients I see once a year. I mean, if they've had problems with depression, they're on an antidepressant, I'll see them one time a year. There's no reason to see them more.
That's reasonable. You don't think $1,000 for 1 year. I was thinking, you kind of come back once a week, once a month.
Oh no, we don't do that once a week stuff, and we don't even do once a month on an ongoing basis. I'd probably want to see you at the beginning and then within a month, and maybe a month after that. But then the appointments are going to start getting spread out. Yes. Do we have a DHEA? Yes, we do. It's DHEA sustained release from Nutriscriptives. You can't buy it on Amazon or any other place.
What's it run?
What's it run?
How many tablets?
For how many tablets? It's about $35 for 100. Okay, and I'm getting the sign back there. So you've all been a wonderful audience to talk to. Thank you very much.